Kia ora and good morning to everybody and welcome to this session. For those of you who don't know me, my name's Alicia Spittle and I'm a physiotherapist and researcher and clinician from Melbourne, Australia, and also a GM's trainer, and have spent many years looking at early detection of cerebral palsy, and it's great to see the progress that you've made in New Zealand. And some of you might know that my family are from New Zealand, and I'm very passionate about supporting both clinical and research work in New Zealand. But this morning, it's not about me, it's about the great work that you're doing. And I'd like to introduce two of the presenters for this morning, and then we'll have some discussion. So we've got Angelica Fletcher, who's a neonatologist working in the neonatal intensive care in Wellington Regional Hospital. And together with Dr. Sneha, she is the co-lead for the CP Clinical Network in Early Diagnosis and Intervention Working Group. And she's also got a keen interest in clinical practice improvement, particularly in neuroprotective and neurosupportive NICU practices, and is also trained in the GM's assessment. And Dr. Sneha Sadani is a paediatrician at Waikato Hospital and an honorary senior lecturer in paediatrics and child health at the University of Auckland. And she specialises in neurodevelopment and disability, and she's working as part of a multidisciplinary team. To improve referral systems for the NICU and involving visits to neurodevelopmental teams and early intervention providers in the city. So I'll hand over to both of our speakers for the next session. Thank you.
And thanks for inviting us to come and talk to you about all the work that a big group of people have done over the last year and a half or so in terms of early diagnosis of cerebral palsy, intervention and surveillance best practice recommendations for New Zealand. I just want to acknowledge the Cerebral Palsy Clinical Network, who Sue Stott shares, and our group that we are co-sharing, which involve a lot of the speakers that are here today, including Dr. Anna Mackie and also Malcolm Batten, neonatologist in Auckland. And we also have a lot of support from physiotherapists, Sally Kidd and Mike Powell, as well as support from parents and families that have the lived experience of cerebral palsy. So just an outline of our talk today. Just talk a little bit about the importance of early diagnosis, and you've already heard a lot of that already this morning. Then we'll go through the best practice recommendations for early diagnosis in children less than and up to 5 months of corrected gestational age, as well as above 5 months of age. We talk about the assessment tools, and if we have some time, we may cover some of the classifying severity and motor type of cerebral palsy as well. So just a little bit of my background. People often get a little bit surprised that as a neonatologist, I spent a lot of time talking about cerebral palsy diagnosis in older children. During my training, this is often what we do and what we see. Our days are quite intense, and through my training, a lot of the focus was always on survival. There's a lot of machines to go beep, there's lots of exciting machines that we have, there's lots of high adrenaline things that we do. These pictures are from our unit, and these are a lot of the lovely colleagues that I work with every day. But really, for me, what it has become more and more about is really our patients and how we can support them from when they come to us, or even before they're born, to ensure that the outcome is as good as they possibly can be. And this is both for our very early born babies, but also our term babies. So really a lot of this comes down to how we can prevent and minimizing neonatal brain injury. And that's how I feel that all the work that we do every day comes down to this. And it's also around all the work that's done before babies come to NICU or to special care units. It's about making sure that we have appropriate and equitable antenatal care. It's ensuring that everything we do around the timing of birth, together with our obstetric colleagues, are to the best of our ability. It's about what happens postnatally in terms of supporting babies that come to us that may have high risks of neonatal brain injury, and what we do during the time with us. But no matter what we do and what our colleagues do, we can't prevent everything. And we know that a lot of our babies, as you've heard earlier today, do have a high risk of cerebral palsy. And the key then becomes that we can diagnose this as early as possible to make sure that we can influence the outcome for these babies. A lot of the questions I get is, does it really matter? We will find out in due course. But it's really about optimizing the motor and cognitive neuroplasticity that we know that these babies have. These brains are amazing, and we can see that through their journey with us. We know that the window for the most optimal optimization of this is really in the first 2 years of age, or 2 years of life. And if we don't recognize and we don't diagnose the problems that these children may have until they're 2, then we've missed a lot of that opportunity. And we know that if we do get an early diagnosis, that we can help and try to prevent and minimize a lot of these comorbidities that come with cerebral palsy that we already heard a lot about today. It's about improving the functional outcomes. We know that we can't necessarily cure cerebral palsy, but we can really do a lot to improve what happens with these children and their life for the rest of their life. We can help how they how we can increase their participation in all areas of society. And also importantly, we can really work with the families and their satisfaction and their quality of life and their mental health, and really make sure that we can provide sort of timely support both for parents and their whānau. So I'm not going to dwell on this a lot, but a lot of the things that do come up is that we don't have a definite biomarker or test or criteria for cerebral palsy, and that's a big barrier for early diagnosis. There are a lot of concerns in regards to misdiagnosis and to giving a diagnosis too early that then proves to be wrong. And I'm just going to talk to you about the path that we can go through to diagnose today. And we know that following that, the numbers of misdiagnosis are very, very low. They're less than 5%. And even within those children, they may not be diagnosed with cerebral palsy in the end, but most of them end up having some other neurodevelopmental disability. It often also comes down to not necessarily having the time and having the difficulty to actually have these conversations with families and whānau, and the grief that comes from a diagnosis of cerebral palsy. But from my own experience and from a lot of my colleagues in different disciplines, we know that families already know and often suspect that it's something that's not quite right. And often the most difficult part of this is not knowing, and having a diagnosis helps them to move on and help them support their child. This has already been brought up, and Alicia, who's with us today, is one of the co-authors of these papers that really, to me, changed a lot in 2017. It's a literature review, an international literature review that also then put together really suggested pathways for early diagnosis of cerebral palsy. And it proved to us all that cerebral palsy can now be diagnosed by 3 months of corrected age. And this is by combining motor assessment, neurological tools, and neuroimaging. So from this, as part of our clinical network, we know that these guidelines are out there, but we wanted to create something that was aimed at New Zealand. So we haven't reinvented the wheel, but what we wanted to do was to create a guideline that was, or best practice recommendation for New Zealand and for Aotearoa. So what we wanted to do in terms of our aims was to promote best practice evidence and equity. We really wanted these best practice recommendations to be a guideline for all types of health professionals in all types of resource settings to be able to provide early diagnosis and get guidance for early intervention. So part of this is not just about early diagnosis, but we've also worked on putting together a checklist for early CP-specific therapy and intervention to help guide different health professionals We wanted to relate to New Zealand's unique culture and the health service that is here in New Zealand. And really we wanted it to be something that could promote consistency and equity for all children and whānau around New Zealand. So the scope for this is really infants and young children that have a high risk of cerebral palsy or they have a diagnosis of cerebral palsy in the age group between birth and 2 years corrected age. And once we put together the draft, it had gone out into consultation with lots of different stakeholder groups that you can see there, including New Zealand Child Development and Disability Clinical Network, the Paediatric Society, the Newborn Clinical Network, the Physiotherapy Special Interest Group, and also families, individuals with lived experience of CP. And to be bold, one of our main goals, together with this CP strategy in New Zealand, Australia, is that we want to increase the number of children with cerebral palsy that are diagnosed before 12 months of age up to 70% from where we are now, which is around 40%. I've been hoping that we could actually go through the best practice recommendations today live, but unfortunately they're not quite ready to go up live on the website. But this is a screenshot of what it will look like. So it will be on the Starship homepage. It will be under health professionals and the New Zealand Child and Youth Clinical Network guidelines. So be able to be accessed no matter where you are. The way that we've set it up is that we have a brief introduction around cerebral palsy and early diagnosis. And there will be a scrolling document, but you don't have to read it all. You can go to the section on here on the left side, which is most appropriate to the patient in front of you. So it will be a section for diagnosing cerebral palsy in children up to 5 months of age, after 5 months of age, and also be sections with guidance around clarifying the severity and motor type early, about MRI and the MRI findings, about motor severity. We're also hoping to develop further resources around communicating the diagnosis, and then also having links to our early intervention checklists and surveillance, which would then also include HIT surveillance that we've heard a lot about already today. This is a very aspirational document, so we know that we are not able to do all of this in New Zealand at the moment, but we wanted and we thought it was important that we had a document that we could all relate to, where we know that what was the best practice recommendations for our children. And this is a living document, so we see that this will continue to grow as we learn more, and also when we learn more about what we can do around New Zealand. So I'll just talk a little bit about the pathway and about early diagnosis of cerebral palsy in the age group less than and up to 5 months corrected gestational age. And the main tools that are used in this pathway, which is general movements assessments, MRI brain, and the Hammersmith Infant Neurological Examination, or the HINE. The algorithm is really the combination of these 3 tools mainly. And we know that they have been used for a long time. And just from my own experience, going through my training, MRI was the main tool that we used. And I actually became an advocate for a while that we shouldn't be using MRIs, because they could show us a lot or they could show us nothing. But at the end of the day, it didn't help me to actually tell the parents what to expect. But together with these 3 tools, so the general movements assessment, which we know have a really high sensitivity and specificity, over 95%, the MRI, which have a reasonably high sensitivity, and with the HINE, that again has a high sensitivity and a reasonably high specificity. But using them all together with our own clinical assessments and with the history, together now with all the 3, we can actually reach a sensitivity above 97% and a very high specificity. So deciding who to screen, of course, is difficult. It'd be nice to be able to screen every child, but we can't. So as the first step, we put in that we want to recommend that all infants born before 30 weeks gestation get screened. or infants born after 30 weeks gestation but have other high risk factors for cerebral palsy, which may be low birth weights, severe growth restriction, abnormal neurological findings or neuroimaging findings. Children that we do know have hypoxic ischemic encephalopathy and do get cooled. Children that have other encephalopathy pictures of other etiology or unknown etiology, and infants that have cerebral infections early, meningitis or encephalitis. Not everyone will fit into these criteria, so we've also put together pointers in history that may give you a reason to look a little bit closer at this child and also consider if this infant will be reasonable to put them through the screening process. So what we wanted was a really easy to follow flowchart for people that have, may have knowledge about the different tools or don't, but just have a really easy flowchart which is based on a timeline to know when to do what. And this is something that we're hoping can just be something that we can print out, have next to your computer or in your office or in your clinic. So the process really starts for this early group with identifying risks for cerebral palsy, or if this infant meets the criteria for cerebral palsy screening. Then we recommended at least 3 general movements assessments. We know that having many of them can be helpful because we are interested in the trajectory, not just in one assessment, but we thought that 3 would be a reasonable number. And we've recommended that we have 1 in each time period. So 1 in the preterm period, at least around sort of 32 to 35 weeks, 1 around term, and then 1 at around 3 to 4 months corrected gestational age. We have also put in an MRI at term. We do realise that the resource is definitely not always available, and we definitely need to think about how and which children do get an MRI at term, but we have left that in as the best practice recommendation. At 3 months, around 3 months corrected age, with the general movements assessments, we've also put in for the Hein assessment to be done, as we know that this is the time when this sensitivity is the highest. But there is also an alternative pathway if the general movements assessment or an MRI is not available, with other tools that can be used. And so once you reach this timing around 3 to 4 months corrected gestational age, we will also provide a bit of a guidance on how to combine the assessments and be able to give either a diagnosis of cerebral palsy or more likely give the diagnosis of high risk of cerebral palsy, which will get this child on the right pathway for the right intervention and screening, or down to the low risk of cerebral palsy pathway, which we will talk a little bit later on. And I'll just now hand over to Sneha to talk about the after 5-month pathway.
So I'm going to be talking about the steps for the diagnosis or establishing the diagnosis after 5 months corrected gestational age. So we'll start with the step 1, which is criteria for cerebral palsy screening. Now, this is again, like Angelica put it into context around her neonatal work, and the same holds true for me. So being a neurodevelopmental pediatrician working in Waikato, I owe a lot to my team at the Child Development Center. They have worked really hard to develop pathways of care, transition of care from the newborn unit through to the neurodevelopmental pediatric services. And again, having standardized pathways, and we've used these words before, standardized assessments, standardized MRI findings to help guide early intervention is part and parcel of the work that we do in a multidisciplinary setting. So it's a criteria for screening, for cerebral palsy screening after 5 months corrected gestational age. This holds true for kids who have recognized antenatal perinatal risk factors or not. And just going back to the clinical history indicating risk for cerebral palsy, which Angelica has covered in her the screening criteria for kids admitted to NICU or special care unit. Neurological risk factors, that is gestation, depending on the gestational age, the birth defects, IUGR, abnormal neuroimaging, or hypoxic ischemic encephalopathy, and infective processes. And parent-identified concerns. Now, we all know that parent-identified concerns over 5 months of age are absolutely, we do need to bear that in mind, because if the parent is worried, then yes, we should worry, and we should definitely be screening these children. The criteria, the clinical signs that, or the clinical features that prompt referral for diagnostic workup, and these are things that we all know, and we teach our medical students and GP colleagues. So these are your neurodevelopmental red flags: persistent head lag beyond 4 months of age, fisted hands or closed hands after the age of 4 months, consistent asymmetry of posture and movement after the age of 4 months, stiffness or tightness in the legs 6 to 12 months of age. So children who are unable to bring their toes to the mouth, when they're having their nappy changed, etc. Kids who are unable to sit without support beyond 9 months of age, early hand preference, and delayed walking, not walking by about 18 months of age. All these are risk or clinical features that prompt a referral for diagnostic workup. The signs are persistent moros, that is, moros, so any of the newborn reflexes that are persisting beyond 6 months of age are red flags, and then consistent toe walking or asymmetric walking beyond 12 months of age. Now, of course, these are red flags, neurodevelopmental red flags pointing towards cerebral palsy, but also a whole host of other diagnoses. One of the articles that I found very, very useful is, it was in the recent archives, and it's an update to a previous article in 2014. It's by Richard Appleton, that talks about cerebral palsy, not always what it seems. And they go over all the motor signs, and I definitely recommend reading that article. So it's all about the motor signs and the motor signs like ataxia, spasticity, predominance of diplegia, triplegia, dystonia, all the other conditions that present or could be misdiagnosed as cerebral palsy. And that is, again, useful information for us as clinicians. So these are the criteria for cerebral palsy screening. What happens next? Once the kids have met the screening criteria, you move on to mainly 3 steps, really. So step 2 is using your 3 tools: a neurological assessment, which is HINE, Hammersmith Infant Neurological Examination, and then MRI and standardized motor assessments. So the HINE tool, again, I have to thank my colleagues at the CDC, especially my physiotherapy colleagues, who have taught me all I know about HINE and the standardized motor assessments. So particular thanks to Carly Joel and Tanya Johnston. These girls are involved in the transition pathways and in the neonatal high-risk pathway that we've got set up at Waikato. And of course, Shan has been around the country training all of us. So I got trained to do the HINE thanks to Shan. So HINE is Hammersmith Infant Neurological Examination. I will go over the details of how HINE is done if time permits, but scores of less than 59 at 6 months corrected gestational age, less than 62 at 9 months corrected gestational age, and less than 65 at a year are 90% predictive of cerebral palsy. So scores less than 73 at 6, 9, or 12 months should be considered high risk of cerebral palsy. And HINE scores of less than 40 at 3, 6, 9, or 12 months almost always indicate cerebral palsy. And as I said, I'll go over how we administer the HINE and how the scoring is done if time permits. We then move on to the step 2, so the neurological examination, then imaging. So MRI scans, and we've spoken, Malcolm has spoken about MRIs, Angelica has spoken about MRIs within the newborn unit. So well-defined lesions will be seen or can be seen early, but subtle white matter lesions may be difficult to detect. And this all depends upon, it's because the brain's still myelinating. Repeat scans will then be thus recommended at age of 2 years for infants with initial normal findings on the MRI, so term MRI or 12 to 18-month MRI, if that's normal, but there are persistent motor or neurological abnormalities combined with the standardized motor assessments, those children will need repeat MRI scans. I think what we do remember, or we have to remember, is the whole principle of activity-dependent plasticity. So early detection, one of the guiding principles for early intervention, early detection and early intervention will influence outcomes and affects the activity-dependent plasticity of the brain. So that's about MRI scans. Of course, sedation, so the resources are different in different areas, and sedation may be required after 6 weeks of age, up to 2 years of age. Then we move on to the standardized motor assessments. So DAISY, or Developmental Assessment of Young Children, this is 89% predictive of cerebral palsy. Parents self-report and quantify the motor delay. And you can, of course, triangulate these findings with other additional standardized motor assessments like Alberta Infant Motor Scale, AIMS or AIMS. And that's 86% predictive of an abnormal motor outcome. And NSMDA, which is Neurosensory Motor Developmental Assessment, 82% predictive of an abnormal motor outcome. We can go over these if time permits. Step 3 is a alternate pathway. If the MRI or if imaging is not available, then the alternate diagnostic pathway may be used, and that is again using your standardized neurological assessment. Hein scores, like I said before, if you've got scores of less than 73 at 6, 9, or 12 months, corrected gestational age, these kids should be considered high risk of cerebral palsy. Hein scores of less than 40 at 6, 9, or 12 months corrected gestational age almost always indicate cerebral palsy. And then you combine with other standardized motor assessments like DAISY, which is 89% predictive, and MAI, which is motor assessment of infants, which is 73% predictive of cerebral palsy. So in my neurodevelopmental clinic, sitting as a clinician, seeing the children who have transitioned through the newborn unit with high risk, screened as high risk to be on the high risk pathway, and they've had Hein scores done by my neurodevelopmental therapists and the physios, that helps triangulate findings, helps counsel families, talk about prognosis, talk about diagnosis very clearly. So the pathway, so this is, I've just spoken through the steps, and this is what it will look like, and this is what's going to come through on the website. I'll just simply, that looks really tiny, I apologize for that, but just to simplify it, starting point was to identify which children meet the criteria for CP diagnostic workup based on the history and clinical examination. Best diagnostic pathway is using the Hein along with MRI brain and DAISY, a developmental assessment of young children. And again, you can combine that with an AIMS, Alberta Infant Motor Scale, or an NSMDA. Alternative pathway, if the MRI is not available, is your Hein along with DAISY plus or minus the motor assessment of infants. You then combine all the assessment data. And then the next slide that I'm going to talk to really is the combined assessment data, either if you use the under 5 months pathway or the over 5 months pathway for early diagnosis. And again, this is what it's going to look like. You land up with a diagnosis of cerebral palsy or high risk of cerebral palsy, or a diagnosis of low risk of cerebral palsy or definitely not cerebral palsy. If it's low risk or not, then we recommend continuing your standardized neurodevelopmental follow-up, early intervention, testing for differential diagnosis and relevant associated and addressing relevant other impairments as indicated. If you have made a diagnosis of CP or high risk of CP, then you can determine the preliminary severity and topography based on your Hein and neuroimaging findings. And again, we will talk through this in this talk. You should assess for associated impairments and other medical conditions. Communicating outcomes, I think that is a session that's going to happen this afternoon on our CP Education Day. Arranging for enhanced follow-up surveillance and intervention based on most likely type of cerebral palsy. And of course, consider a referral to the pediatric neurologist and or the geneticist in particular if there is an absence of known antenatal or perinatal cerebral insult, if you've had a normal MRI, if there's any progression in or development of new clinical signs or a family history of cerebral palsy. So this is almost an exit from the sort of CP pathway if there is any concern around a different diagnosis. So putting it in a guideline will hopefully keep us all on track as to, what are we thinking of, what is the etiology here. And then, of course, arranging for parent or whānau support and providing information about the CP Society and CP resources on kids' health, monitoring, confirming diagnosis, and then notifying the New Zealand Cerebral Palsy Register, which is, of course, extremely important. And Anna has spoken to that this morning. So this is once you've combined the assessment data, either by following the under 5 months pathway or the over 5 months pathway. This is the best practice guidance for us. Hopefully that'll help. I'm just trying to, yeah, I think I will have to hand over. So Angelica is trained in GMs and I'm trained in HIND. So we're going to divvy this up again. And Angelica is going to talk about general movement assessments and how to interpret them. Over to you again, Angelica.
Thank you. So just briefly, we just wanted to talk about, see if I can now take you off now, sorry, so I can move this along, hopefully. So just talk a little bit about general movement assessments, and I know a lot of you here today will already be trained, but what we really, what we know and what we look for in infants is what we call general movements, which is a sort of typical and distinct general movements that we can see already in the fetal life from around 9 weeks gestation. And these movements are generated by a variety of motor sort of pattern generators. And then these movements are modulated by the brain and will differ depending on if you've got a healthy, normal developed brain or a brain that may have been subject to injury or maldevelopment. So these movements change according to a trajectory from when they first appear all the way through to around 20 weeks, correct, the gestational age, when they disappear. So that's why we can't use them later on in terms of diagnosis. There's definitely a link between these movements and how the brain develops. And no matter when you're born, the schedule of how these general movements change follow a certain set schedule. At the moment, we have just above 50 different health professionals trained in New Zealand, ranging from neonatologists, paediatricians, neurodevelopmental therapists, physiotherapists, etc. And we often get our parents involved to also do these assessments in terms of filming these babies. So what the assessment is like is that it's a video that we take, which can range from minutes to, well, usually at least 2 or 3 minutes, but often much longer than that. And that is then assessed by usually a group of professionals, just to making sure that, that we get an agreement to what we see. So just looking at the trajectories of the general movements. In the green are the normal general movements that we look for, that we can see already from the early premature age. And they are preterm writhing movements that then go on to change into term writhing movements. And they continue up to around 9 to 10 weeks post-term. And they have an overlapping with the fidgety movements, which occur or appear around sort of around nine weeks gestation, but we often see mainly around closer to 3 months of age. So we have then recommended that we do the fidgety movements assessment between 12 to 14 weeks ideally, and that they do get repeated if there are any abnormal or absent movements at any time. So this is what we're hoping to see, which is in the green. But what we also do see, and we often see in preterm neonates, is poor repertoire. So this is when we have a brain that may not be fully developed yet, or we have injury to a brain where we can often see cramped, synchronized or chaotic general movements. They're often much more, in terms of poor repertoire, they're often much more monotonous, while we, with the normal preterm general movements, see a much more variety in our movements, both in terms of the movements we see, but also in terms of amplitude and speed, and the smoothness of them. When we get to the fidgety time, what we would like to see are the fidgety movements, but when we get concerned are when we see the absence of fidgety movements or abnormal fidgety movements. And the movements that are the strongest sort of linked to a diagnosis of cerebral palsy are the sort of persistent cramped synchronized general movements assessment at the late preterm time or early term, and then the absent fidgety movements at around 3 months of age. And I'll hand over again to Sneha to talk about the Hein assessments a bit more.
Thanks, Angelica. So we spoke briefly about this, the Hammersmith Infant Neurological Examination. And again, I have to thank Carly Joel, Tanya Johnston, and Sean Williams, because I know this only thanks to them. So it's a simple, quantifiable neurologic examination for infants from 2 to 24 months of age. About 100 professionals, health professionals have been trained in New Zealand. And it's for use in conjunction with clinical history, neuroimaging, and your general moment assessments. Or when MRI is not available or a window for doing the general moment assessments has passed, then the Hein is an extremely useful tool and easy to administer and interpret. So it essentially consists of, let me just move the slide along. Yeah. So it consists of 26 items that assess different aspects of neurological function. A score between 0 to 3 will be assigned for each item in each of the 5 domains. So there are 5 main domains. First one is the cranial nerve domain, cranial nerve function domain, which has 5 items. Then there's an assessment of posture, which has got 6 items. And then the third one is assessment of movements, and that looks at the quality and the quantity of movements. And then the next bit is the assessment of tone, which has about 8 items. And the last part, which is scored as 5 items, which looks at reflexes and reactions. So that's on the left side, the assessment of tone and reflexes and reactions. The section 2 and section 3 look at motor milestones and behavior. Now, these are all age-dependent items that reflect that kind of give you an idea of gross motor and fine motor development, function, and behavior. But those items are not scored. So that's a Hein, and it's useful as in the maximum score that you can get is 78 for the 26 items that you've administered. Optimal score is over 72 for a 12-month for a year-old infant. And then we've got the cutoff points, which help you predict cerebral palsy. So the cutoff point, 3 months corrected gestational age. If your score is less than 57, then that's 96% sensitive and 85% specific for a diagnosis of cerebral palsy. And likewise, if you look at the year score, if your cutoff point is 65 or less than 65, score is 91% sensitive or 90% specific for a diagnosis of a prediction of cerebral palsy. A score of less than 40 at 3 months of age is predictive of severe cerebral palsy, and that's often very helpful in counseling families or giving prognosis as well. We've touched upon MRI. Malcolm and Angelica both have touched upon that. And the MRI, the classification system is, of course, the classification A, B, C, D, E is that identifies typical MRI patterns associated with the specific timing of brain compromise is very helpful. So we've got here maldevelopment, which is disorders of cortical malformation. So that occurs in the first and second trimester, the brain compromise, and those are conditions like lissencephaly, polymicrogyria, cerebellar hypoplasia, corpus callosum agenesis. Those are the ones that we see as clinicians. Type B is the predominant white matter injury, and those are early 3rd trimester injuries, and that's periventricular leukomalacia mainly, so as a consequence of severe IVH in periventricular leukomalacia. And then predominantly gray matter injuries in your late 3rd trimester, so that's cortical injury, hypoxic ischemic encephalopathy, basal ganglia, thalamus affection. And someone had mentioned earlier, like I think it was Tim asking, why don't we have neuroimaging standards? Of course, that would be very helpful when, as a clinician, you see them in clinic. You've got you've got an image, you've got a pattern, you've got the Hein findings, and a standardized motor assessment, which helps you put it all together and start off with early intervention and counseling. So neuroimaging findings are abnormal in 80% of the children with CP. Again, these were findings that Malcolm shared with us. The use of MRI and knowledge of its role in understanding the CP pathogenesis has drastically changed over the last 15 years. And we used to say, we don't need a normal MRI. It does not exclude a diagnosis of cerebral palsy. And there are limitations around resource availability, but it helps disclose the pathogenic pattern responsible for CP, so helps you understand the pathogenesis and often also the etiology. And MRI findings are also increasingly being introduced into the New Zealand cerebral palsy registers. And our aim is, and I think Anna is collecting data around that, our aim is to introduce that or include that in the CP register. We've always said this will help determine why the infant has CP etiology, and helps in understanding the structure and function relationship. And then moving on helps look at to determine severity and topography of so the type of the severity of cerebral palsy and the type of CP. That will help us understand that in conjunction with the motor assessment tools. I think I might have to end there. I've got information on other motor assessments, and I don't think we've got time to go through that. I'll hand over back to Alicia, and we'll take questions, I think, from here. Back to you, Alicia.
Thank you. Wonderful presentations and a great overview of what we need to do for early detection